Thank you very much. Hello, welcome to this month's seminar, which features Terry Quinn. We're really delighted to have Terry, who's a professor in geriatric medicine, and his research covers a whole variety of cardiovascular, dementia, stroke, but also really interesting areas like clinical methodology and science communication. Within the university, Terry's got a number of roles. He's Professor of Geriatric Medicine in the Cardiovascular School, but he's also Vice Chair of the MELS Ethics Committee, and also is really involved in lots of science communication with the Scottish Stroke Research Network. So there's any number of things that we could ask Terry to talk about, but we wanted to find out more about the BioHermes project. Which has had one call and is about to start another call. And this utilises multi-modal data, imaging, sequencing for stroke and so I'm looking forward to hearing about this. If you're joining online and you've got any questions, then please do put them in the chat or raise your hand and we will get to you. Before I hand over to Terry, though, if you'll just bear with me for 2 seconds, because I wanted to promote two funding schemes that we've got open at the moment. The first one is for training and conferences. This is open to PhD students, postdocs, MPA staff, anyone who's going to go to a conference or for some training that's data and AI related. Then please do consider applying. We also have a fast track one as well, which is within a month within the UK. So if you are looking to go to any training, hello, do come in. So if you've got any sort of training or conferences that you want to attend and money's a bit of an issue, please do consider applying to the centre. We also have a fund for engagement. So this could be engagement within the university or externally with companies, public. Anything that involves outreach to other groups of people, then please do consider that as well. And also, we'd like to promote the next seminar. Our next seminar is going to be Dr. Emance, who runs the XR, the Augmented Reality Lab, which is actually just the other side of the corridor. So he's going to be giving our next seminar, which is actually quite soon. It's on the 9th of May. And he's going to be giving an overview of some of the projects, so things like museums in the metaverse and transit. So do come along, sign up if you want to join us. It's on our website and we'll be promoting it on the screens. Okay, enough of my chat. I will hand over. Thank you very much, Terry. I'll hand over to you.
Okay, so thank you everyone in the room and online. So it's very nice to have that introduction. Cards on the table, it's not only going to be me speaking, you're also going to hear from Kalliopi, Mavromati, probably more from her than me, which is a good thing. Believe me, anyone that's heard me talk knows that that's a good thing. So what we're going to talk about today, as you heard, is the Scottish Dementia Challenge, sometimes called the BioHermes Challenge. And like any good story, it's got a beginning, a middle, and an end. So I'm going to cover really the origin story to all of this. Callie's going to have the main event and tell you about the challenge and what we managed. And then I want to just bookend that by talking a little bit about what we've done since the first challenge. And there will be opportunities there actually for people to engage with other resources and other things that we have planned. So once upon a time, there was a disease called dementia. And there's a country called Scotland. And within Scotland, there were lots of people who worked in the field, but they really didn't work together. That was true across centres, Glasgow, Aberdeen, St Andrews, Edinburgh, all had thriving dementia research groups that really didn't work together at all. Even within one centre, groups weren't working together. Imagine that, academics not working together in one centre. So I, along with others, formed a thing called the Scottish Dementia Research Consortium, which was all about trying to bring people together, trying to create community within Scotland, trying to realise the synergies that we had, because let's face it, we are a small but perfectly formed country. And we did that. We have a photograph here of when we formed. in 2013. At that time, we were very proud to have 100 members. I was and am chair, and was very proud when we celebrated our 10th birthday party in 2023, at which point we had more than 1,000 members. And those were members from across disciplines. So we had researchers, but we also had clinicians. We had people from policy, we had people from third sector, and we had people living with dementia, people with lived experience of dementia, which I think has been very important. So, you know, I was quite proud of that, but I recognised that it wasn't enough. And I recognised that dementia and brain health was really having a moment. And I think in research, one of the things that you need to be aware of is when something is having its moment, and you have to be ready to capitalise on that. And dementia and brain health were having their moment for a number of things that were happening in parallel. The Scottish Government had made a commitment that they wanted to improve the brain health of the nation. And that was in the programme for government. And they had committed a lot of money to having a national brain health service in parallel to the NHS. Now, the truth is that ambition hasn't quite been realised, but nonetheless, that ambition was there. At the same time, and these things are very much linked together, for the first time ever, there were treatments for dementia. Dementia, which is a progressive loss of brain tissue, was something that, to be honest, we never had any treatments for. And that has now changed. We have biological treatments that can halt or reverse the process, and that has led to huge interest in the area. And then again, linked to that, dementia research, which had kind of been floundering a little bit, suddenly became very sexy again, and funders wanted to fund it. And there were a number of huge commission calls, nationally and internationally, looking to fund dementia research. So with the triangulation of these things, I really felt we need to do more in Scotland. At the same time, the Scottish Government put out a call for research collaborations that would exist to try and promote and develop and raise capacity within key areas. And the call asked for you to pitch to government for the most important things that would affect Scotland over the next 50 years. And these then founded ARCs, which were research collaborations designed to improve capacity. So they funded one around food security, which is important. They funded one around net zero. They funded one around quantum technology, food and quantum both based in Glasgow. But they also founded one around brain health, which I've had the absolute privilege to lead. Here is our logo, and here is our little mission statement. And I won't read it out, but one of the things there is to make Scotland the go-to destination for anything related to dementia or brain health research. And as a result of that, I now find myself having many more conversations with industry, small and big pharma, with SMEs, with venture capitalists, and with clinical research organisations. And the story we're going to tell you around BioHermes very much came from a conversation with one of those big North American clinical research organisations. So here is our URL. This is our website. The Brain Health Arc is free to join. We have a mailing list, but we don't spam people. But I would encourage everyone online and in the room to join up. You can do it on your phone just now. And we will keep you abreast of all of the different opportunities that we have. Now, what are those opportunities, Terry? You may be asking. Well, here's what we've been doing since we started around about 18 months ago, 2 years ago. We've been looking to shape policy. I found myself in Westminster and Holyrood more than I expected, and that really has been effective, and brain health and dementia is very much on the policy radar, both in Scotland and in the UK. We've been trying hard to create community. We've been doing that through our mailing lists, through having themed meetings, through our online presence, through meetings like this, trying to bring more people in. We realise that there's a pipeline problem. There aren't enough new people going into dementia research. So we have a big theme around supporting people who are earlier in their research journey. And we have training, and we have mentorship, and we have webinars. But the thing that I want to focus on, or rather I'm going to hand over to Callie to focus on, is we went into this with an ethos that any resource we were given, we would share with the community. I wouldn't keep it for my lab. I wouldn't keep it for University of Glasgow. Any resource that came to us in the ARC, we would share with all of Scotland. And that's exactly what we did with data. So before I hand on to Callie, I just want to spend a minute talking about data and talking about open data. So open data is a real buzzword at the moment. If you do any data-driven, certainly any data-driven biomedical or clinical research, you need to talk about open data. But some data are more open than others. Let's be honest. When people get hold of a data set, it's like the precious. You squirrel it away in your lab, and you maybe let some of your ECRs work with it, and you turn the handle, and you get lots of papers for yourself. But that's not what the people that provided that data wanted, and actually it's not good for the community. So what we wanted to do in the ARC is really challenge that a little bit, because we reckon that you can say your data are open, but it's actually not open at all because you have to pay an exorbitant fee to access the data. Happens an awful lot in biomedical. You can tell me if it happens in other spheres. You can say your data are open, but the process to get the permissions to actually have a look at that data is such a pain that eventually you get up and you don't really access it at all. You can say your data are open, but actually lots of bits of the data may be redacted or restricted, so you can't actually work with it in the way that you wanted it to. You can say your data are open, but it exists on a platform that uses bespoke software that no one outside of your lab knows how to use. And so eventually, again, it's not open at all. And you can say your data are open, but it might exist in a format that no one knows how to use. So there are data that are open. We wanted to really give something that was truly open access data, open to everyone in the community, regardless of their background, regardless of where they work. To make a data set open is not something you can do alone. And I have to thank all of the different partners that came together to support the challenge. We had very generous funding from the fund Race Against Dementia. We also had funding through the Scottish Funding Council through the ARC. And we had a number of partners. We had Synapse as a partner, who are another research pooling organisation. And although universities across Scotland were involved, the main partners were Glasgow and St Andrews. And this wasn't just a Terry Quinn gig either. I mean, actually, my part in it was quite limited. It was much more a team of other people. To make the data open and to make it fully accessible to everyone, and you're going to hear more about this from Callie, I brought in a statistician to help you with the stats. I brought in a trial manager, that's Sheena, to help with the day-to-day management, and I basically brought in a superstar to help make the whole thing work, and that's Callie. So at this point, I'm going to hand over to Callie, and she's going to actually tell you about what we did in the challenge.
We are going to get into the nitty and gritty of the situation. So Terry touched on who we worked with, but I want to go into it in a little bit of more detail. We started knowing that there is a community of researchers with the expertise, with the skills, with the labs, with the centers, with teams of people who are all interested in the same things. So we were offered, because we worked very nicely with our partners at Global Alzheimer's Platform, we were offered a really, really expensive and also expansive data set of biomarkers in a cross-sectional study. We'll talk about that in more detail later. But with that in mind, they also offered to work with Alzheimer's Dementia Data Initiative, ADDI, now AD Data Initiative, who offered to host a data set for us. Now, ADDI is an existing platform, so it already was hosting other cohorts, but they were willing to help us actually open up the BioHermes001 data set to other teams. But that's all nicely and said. How do you actually do that? How do you actually achieve that? We broke it down into 3 key barriers that we saw were really limiting who had access to the data. The point isn't just being able to say, I applied and got it. It's also being able to apply to it, quickly access it, know what you're accessing, and also know how to work with it in a time frame that does not exceed, for example, a short-term postdoc contract, or the time a mature PhD student has before they need to start writing their final thesis. So we basically saw this as 3 specific barriers that needed to be addressed. And I'm going to show you how we address each one rather than talk in theory. The first was who has access. Now, Terry mentioned this briefly. When we talked about open data, if you go online and you just look up dementia cohorts online, you'll find various different data sets. And you'll find about 100-page long documents that give you all the information you need to know about the clinical studies that were conducted in order to collect the data. So you'll be able to find all the information there, and you'll probably also be able to apply to it. But That also means that you need to have, if you're an ECR, you need a supervisor, or if you're a supervisor, you need to have the time and resources and expertise to both apply to it, get access, and work with it. So rate limiting step is who knows about this? And the fact is that research does work in labs, that's not going to change. But those labs with the same interest can be reached to pull together their resources and ideas. And that's what we did. So we worked with Synapse and the Scottish Dementia Research Consortium in order to try and reach researchers, and we did. We reached, the map speaks for itself really. These are just locations, not universities, where we were able to reach researchers with an interest in dementia research and or biomarkers and or predictive models and applying them to large data sets. And we also specifically wanted to qualitatively change who has access to the data. What do I mean by that? I mean that we didn't just want medical students who happen to have a year-long contract to do research. We didn't want a specific kind of person to be able to access this. We wanted to open up the variety of ideas we wanted. And to do that, we reached researchers at various career stages, PhD students, research assistants, postdocs, fellows, professors, medical doctors who were in some way working with researchers. We also made it mandatory that there be an equality, diversity, and inclusion consideration, which we opened up to teams to address either in the makeup or in how they were going to run their analysis. And we also prioritized applications that were collaborative groups across disciplines and institutions. So essentially, there were some applications with just 1 or 2 people in the same lab, and they were not prioritized. Instead, we focused on supporting teams that had interdisciplinary teams and at various stages where possible, career stages where possible. We did get over 100 individual researchers involved with 45 applications, if I'm not mistaken. And we even brought together some teams, creating teams of teams, essentially, where there was shared interests and research questions. But enough of that. I also want to talk about how we actually got all of those researchers involved with the data set, which is, in my opinion, one of the novelties of the challenge. And that is we streamline access. So I mentioned there that when you want to apply to, if you just go on and you find a data set that you want to access, you'll find the documentation for it, and you'll also find an application route. That application typically involves you contacting somebody, fulfilling an application to access it, then having them review it, then them also, possibly you might have to submit an ethical application to your department as well. All of those things can take months, and contingencies can really delay that process. We instead secured a blanket ethical application, which put the onus of checking who has access to the data on us. We made it our responsibility to check that the teams who would access the data set would have the experience and the knowledge to investigate appropriate research questions for the data set. That is a crucial step. And also that they would be equipped to handle it. If not, we would also support them, but I will talk about that in a bit. What you're seeing on screen now is all you have to fill out to access this data set. I repeat, that's all, 6 pages, that's the application. All you have to do is tell us what you would like to investigate, some details about your methods, how you are accounting for all of the considerations I mentioned earlier, we made a requirement, and what parts of the data set you would like to access. Through this process, we then checked everything and made sure that, for example, we did have to reject some teams because we felt that some teams were not asking the right questions for the data set, or perhaps they were not equipped to securely handle this data set. That's what I mean when I say we put the onus on us rather than multiple departments and multiple resources and multiple teams of people to focus on checking that the right people are accessing the data set. Once we approved your application, you then read and sign there at the bottom that you agree and stipulate to the conditions of accessing the data set. 3 pages, you read that, and that's your data governance complete. That's it, 9 pages total. That's huge. If anybody here works hands-on with data, you probably are aware that data governance can look very, very different depending on where you go. So the 22 projects that were successfully reviewed upon their first application, then signed this 3-page data governance to make sure that they understand how what their responsibilities are in using the data set. And so now we come to the part, what happens if you have the knowledge, if you have the right question, or you're building towards the right question, but you don't have the expertise to run it, or you don't know how to use the software that's available. Now, the platform we're working with, I mentioned ADDI, was providing standard software. So R, Python, key things, including a very simple click and point analysis tool were available on the platform. But still, there were quite a few researchers who, for example, only knew SPSS, or who had the right questions, but the ideal method with which you would answer them was out of their expertise and skill level and experience level. What I'm saying is we have teams of people who either had the right question and not the skills, or the skills to analyze it, but couldn't figure out what the right question was to ask. And this is where we come in. I think I did say that us streamlining access was a novelty, but I think the biggest change we made is in addressing this third and huge barrier about supporting data work. I don't want to understate how important our achievement was here, because I think it will only make sense if you look at the data set. So let's have a quick look at what we were offered. I mentioned it was a very expensive and also expansive data set. It was expensive because it's a cohort of 1,001 participants. That's 1,001 people that a clinical team went out to recruit, specifically in areas where they would be able to reach individuals from populations that are typically underrepresented in dementia research. That is hugely important, because a lot of the cohorts you will find online will be predominantly white or from predominantly high socioeconomic status areas. So it's really important that this cohort is specifically trying to reach people about whom we don't have enough evidence. It's really difficult to generalize conclusions when we have nothing to go off of. So that's part of why it's really expensive, but it's also really expensive because it contains so many biomarkers. For all of those 1,001 people, we have blood samples, which were analyzed in more ways than I can number to you. We have PET imaging scans and their conclusions, and we also have cognitive testing and functional testing and data from their partner and also their demographic data. If we take a look at what that means for the size of the data set, every single bullet point here is a 1,000-row, multiple dozen column wide data set. That is really difficult for someone with the right question to navigate. And I would argue that even if you have the right skills, if you're not somebody who is a clinician or who has worked with clinical data before, it's really difficult to make sure that you are applying your method and your analysis in a way that is valid for the cohort. This is where I mentioned to you earlier that if you go and find a data set you're interested in online, you'll find a 100-page document for it, and it's going to explain to you what the clinical trial did. If you're an analyst, and again, you have the right question, you even have the right skills for it, how exactly do you navigate 100 pages of details about how this data was collected? It's not feasible. It's actually it's a barrier that is even hard to both quantify and report on. So it might be something that is essentially an invisible barrier there. For that reason, we made it simpler to try and figure out where to find this information. That's one thing we did. And I will use I for some of these things. I made essentially, you can see I have a wee map over there. I found a way to give a bird's eye view of what you will find where. That's a starting point for people to navigate a huge data set. Again, I'm going to go back to my last slide. Every single bullet point on this side is a distinct CSV file. And all of those CSV files come with their own distinct data dictionaries. And every distinct dictionary has its own sheets with different levels of information. So a roadmap view, So this bird's eye view of where you will find what is essential to help you, first of all, map out, can I actually answer my question with the data that I have? Which is a huge challenge. Once you figured out that you can answer it, then the question is, what part of the data set do I use for it? And how do I wrangle it? How do I clean it? Now, this is where I helped give the information about the cohort. Earlier, I showed you this graph. This shows you information about the structure of the data set. So 1,001 people, and about half of those were cognitively normal, about a third were with mild cognitive impairment, and the rest were with probable mild Alzheimer's dementia. that means that all of those groupings reflect a specific diagnosis, which again reflects, I don't want to get too clinical, but I want to recognize that there's so much to this simple label that you must know in order to be able to create a valid analysis around this data set. So it's not just about running this and that, and it's also about understanding what goes into these labels and these features that you're using for your analysis to make sure, for example, you're preventing circularity, to make sure you are covering all your bases when it comes to wrangling values that are out of captioning for the test and things like that. So that's part of the resources we created, but that's not all. We also wanted to support teams to make sure that they would be able to make their questions their reality and produce their results. And we did that in a few different ways. Some teams told us from the beginning, we have this question, we don't really know how to do it. And so from the beginning, we had an analyst, you saw his photo on the screen, Stelios. He and I and our colleagues at University of St. Andrews teamed up with those teams. And we supported them from start to finish to make sure that the analysis met the question that they were looking to get. But down the way, we also found teams had lots and lots and lots of questions. The resources you can see on this slide addressed a lot of them. It helps people take ownership of their analytical work, but also we did have to step in and help with the analysis or help with interpreting things or help with double checking that the information is being interpreted correctly. This is a crucial step because we're talking about clinical data and we are reaching interdisciplinary teams. So that means that as an analyst, for example, there's some things that you just won't know. For example, the difference in one or a different measurement for seemingly the same thing. What does that mean and how do you handle that? There were a lot of these ad hoc questions that we jumped in and supported for various projects at different stages of their project cycle. So having done that, we managed to reach researchers with different expertise and experiences, minimal administrative burden, just 9 pages, you saw that. And we also provided tailored support, not only tailored to the data set and different types of expertise and different experiences going into the challenge, but also project-specific support. And we did that working with over 60 researchers that are actively involved in the challenge. And our achievement is that we, within 1 year, have 22 unique learnings about Alzheimer's dementia, again, within under 12 months, which is crucial because Terry mentioned that research in dementia is having its moment. Why is it having its moment? Because every single time we measure the prevalence of dementia and the impact it has, for example, as a cause of death, it's constantly increasing. So it's really important that we're able to speed up not only the number of things we learn, but also make sure that they're high quality and valid. And with that, I think I'm going to hand back to Terry.
Okay, so there you have the challenge, an end-to-end resource for the community, right from thinking about what your question could be, through to accessing the data, through to analysing the data, through to making sense of it and disseminating it. We offer support at all of those stages, which really is something unique. And just before I go on to the epilogue, just to pick up on something, because some of the people in the room may not be aware of this, Callie described the data set as expensive and expansive. Let me just talk about money. So the Global Alzheimer's platform that collected this data sold it to pharma, and the going rate to have a look at this data, if you are a big pharma, was around $500,000 US. But they gave the data set to us gratis, on the proviso that we made that universally available. So, has what we've done actually made a difference? Has it had any impact? Has anyone taken notice? Well, you know, it's really not very Scottish to blow your own horn. Luckily, I don't have to because other people have done it for us. So there was a special edition of Scientific American all about dementia. One country got its own section, and it wasn't the US, it was Scotland. And that was partly because of the work of the Brain Health Arc. And the data challenge itself, I think because we're offering something novel, because we're offering this end-to-end solution and a topic that is having its moment, I think it kind of caught the public imagination. So, not through any kind of design, but I ended up on TV, on radio, in the papers, we have been given a platform at the biggest dementia conference in the world this year, which Callie is going to present at. They also made a 10-minute documentary on the TV channel That's TV, which I've yet to find on my TV schedule, but apparently it does exist. So, you know, people were interested in this. But featuring the tabloids doesn't really impact. I think evidence of some of the impact we've had is that we have changed the conversation around data and dementia in Scotland. So the data challenge BioHermes was discussed in Holyrood. And following on from that, the Scottish Government Policy Unit have created a specific data group, which I have the privilege of chairing. And we are now looking at realising the power of dementia data in Scotland, realising the power of routinely collecting data, and doing things like creating an index of how many people in Scotland are living with dementia that no other country has done. And if I may, a lot of those conversations began because of the work of the ARC and because of the data challenge and just showing people the power of data to effect change. Now, if you were on social media during the viral pandemic, you'll have seen this hashtag data saves lives. And that was from people who were in the COVID space that realised that the real-time sharing of data around COVID was making a difference. And a lot of our understanding of how to work with data efficiently actually came from that. And I truly do believe that data saves lives. I'm not sure we saved any lives with the data challenge, but I think we did some other things. I think we built teams. Callie mentioned all of the different universities across the UK and internationally that came together. When people approached us to use the data, we didn't mandate, but we strongly recommended that they collaborate with other people. And we had a lot of applications that looked quite similar, and we brought those people together. So I think one of the benefits of what we did was we created new collaborations, and those are collaborations that are continuing to work. They finished the BioHermes project, but they're continuing to work in other fields in the dementia space. That's building the capacity that we need to tackle dementia. Data fosters equity. We've touched on it before, but you know, I'm not ashamed to just bring this up again. To date, data-driven research is not available to everyone in a level playing field. If you come from a centre that has a background in this, doors are open to you that are not open to you if you come from a centre that maybe doesn't have a background in working with big clinical data sets. And we challenged that. We completely reimagined who can and who can't access data. And what we tried to do, as Callie so rightly pointed out, is just remove all of those roadblocks. So essentially, if you had an idea, we would do the rest with you in a partnership. That's true equity. Data drives innovation. We had some quite left field ideas came from the challenge, and that's exactly what you need. More of the same in dementia isn't going to achieve anything. We've had more of the same for decades, and that's why dementia research has really stalled, if I'm being honest. You need new thoughts, you need things that are slightly out of the box, and that's exactly what we got with the challenge, and that's what we encouraged. And we especially encouraged multidisciplinary working. So if we had applicant teams who were just clinicians, we tried to hook them up with data scientists and with people from other areas. So we had teams that would include physicists and biologists working with clinicians, all of them bringing their expertise together to try and do something a bit new, to try and do something that hadn't been done before. And then finally, this is quick. If you want to do a prospective study, go out, find people with dementia, take blood tests, all of that stuff, it's going to take you years, maybe decades. It's going to cost you an awful lot of money. If we have that data already, we can do things really quickly. The data challenge ran over 1 year. And as Callie pointed out, in the space of that year, we've had about 25 projects that are close to completion now, all of them bringing new knowledge in this field. And that is what we need. Because dementia, anyone that has experience of a family member living with dementia will know, dementia moves pretty quickly. So the research community has to move quickly as well. And it's through initiatives like BioHermes that we can realise those efficiencies of time and money. So, if something's worth doing, it's worth doing more than once. I'm very pleased to announce that through Race Against Dementia, through another charity partner of the RS McDonald Trust, we're going to run a second data challenge. Now, throughout the course of the first data challenge, I was learning all the time, and there are some things that we did that maybe I will do differently next time round, and we got feedback. So people said to us, the data set you have is really just cross-sectional. Dementia is a progressive condition, what about longitudinal data? And so I've got some now. People said to us, well, this is a very biomedical data set, what about social care? So I've got some social care data now. People said, dementia is a brain disease, I love brain scans, where's the neuroimaging? We've got a neuroimaging data set. We had lots of people coming from a psychology background saying, we love cognitive tests, can we have more of that? Yes, you can. So the second data challenge is not going to be a single data set, it's really going to be a bit of a buffet of lots of different data sets, and we will have access to BioHermes again and access to other data sets on the AD workbench. Through a colleague at the University of Edinburgh, he has worked to collate all MRI brain scans performed in the NHS in the last 10 years. A fantastic resource, and we're going to make that available through the next data challenge. We have collated all studies of dementia in care homes to speak to that need for social care type data. And again, we have the anonymised individual patient level data for all of those trials that's going to be made available in the second challenge. And we have two big cohorts. We have the prevent cohort and its sister cohort, getting that longitudinal, highly phenotyped data that people were asking for. So this is what the second data challenge is going to look like. If you want to know more, please join us. If you haven't done it already, get your phone out, go to brainhealthart.com and join our mailing list. It's absolutely free, and I promise we won't spam you. And with that, we'll probably stop talking and just open things up to any questions.